These are the future debates in Brussels, and we will be talking about challenges and strategies for biological treatments. First of all, let's do a round of the panel. May I ask each and every one of you to briefly introduce yourself in a couple of phrases?
Claus Bachert, I'm an ENT surgeon, and I run the lab in immunology in Ghent University.
Charles Pilette, I'm a pulmonologist here in Brussels at the UCL, and also working in a research lab in mucosal immunology.
Philippe Rombaux, I'm an ENT surgeon in Clinic Saint-Luc in Brussels, University of Louvain, working with my colleague Charles Pilette.
I am Joaquim Mullol, ENT specialist, working in Barcelona in Hospital Clinic of the University of Barcelona.
Hello, my name is Anne, and unfortunately I'm a patient, and I come from Brugge, Belgium.
Hello, I'm Sandy Kolpaert. I'm a patient too, and I live in Ghent.
I'm Claire Hopkins. I'm an ENT surgeon from London in the UK.
I'm Peter Hellings, ENT surgeon from the University Hospitals Leuven, Belgium, and the Academic Medical Center in Amsterdam.
I am Catherine Lucet, medical doctor specialized in health systems management, and I work at the National Institute for Health and Disability, and I am a payer.
Thank you and welcome. First of all, Dr. Bachert, would you introduce the subject, please?
Well, we talk about nasal polyps today, nasal polyposis and asthma. Now, as I'm not the right person for the asthma part, I just took the current GINA guidelines, make that very short. So if you have asthma, as it is here said, step 5, so severe asthma, then you see the biologics or monoclonal antibodies with different targets coming in for these patients, preferred over oral or systemic glucocorticosteroids. And I think that's a great step forward. Of course, we know that in asthma, monoclonal antibodies have a place since quite some years. For nasal polyposis, this is just now coming. Hopefully, in the next year or two, we will have an indication also for biologics in the treatment of nasal polyp disease. How do these patients look like? This is maybe a little bit of an extreme example, but this is a patient I saw in Ghent, a young person. When I saw him, he was 19 years old, and he had already 3 surgeries within his short life. And as you can very nicely see, there is a tremendous growth of nasal polyps, pushing his eyes to the side. His midface actually is expanded by the polyp growth. And on the right side, you see the eardrum, and even there in the middle ear, he had polyps, and these were protruding through the eardrum. Of course, this patient could not hear well. He had a massive nasal symptom complex, obstruction, no smell at all, a lot of secretions. He has this hypertelorism in the face, and of course, he also suffered from asthma, and in his case, it was severe asthma. Finally, he got a surgery because it was just impossible for him to breathe, and he got a biologic treatment, but not for the nasal polyps, but rather for the severe asthma. So nasal polyposis per se is something to come for treatment with biologics, and it's based on the fact that these patients really suffer. And what you see in the upper row is from a large Galen study, patients looking at the quality of life, a general quality of life score. And you see very nicely that in all domains of this quality of life score, the patients score minor because of their nasal polyp disease. Specifically, if you have asthma, and that is in the most severe patients, about 70% of the patients, and aspirin sensitivity, that's a smaller percentage, then your quality of life even gets worse. You see that down here. You see that down here, and you see that the circle gets narrower and narrower because of that comorbidities. So patients really suffer, and if you saw the picture before, I think you certainly can believe that. On the right side, you see what are the options. Topical steroids wouldn't even come into the nose in this patient. And then there is surgery, but surgery as it is done today in most of the places is obviously not a great promise to many patients. These are not the Belgians doing surgery. These are 3 American university clinics. And you see that of those patients, they operated after 6 months and 12 months, 18 months, about 40% of them already had recurrence of disease. So either we have to think about the way of doing surgery, or maybe also about the way of approaching these patients. Now, why not learn from our colleagues from the lower airways and use monoclonal antibodies in this field? This is a summary of what is available: omalizumab, mepolizumab, reslizumab, dupilumab in former studies. But these are all proof of concept studies with small numbers of patients, and we need to go into phase 3 trials, and there's currently 1 phase 3 trial going on. So we will have to learn for nasal polyposis a lot. In whom we applied, is there a differentiation between different medications to find the best patients? All these are still questions. But I guess that if you take the total of 10 to 15% in the population of chronic rhinosinusitis and 2 to 4% nasal polyps, that 30 to 40% of this latter group, so quite a small group, but really suffering a lot, would be eligible for a monoclonal antibody treatment. So how do we approach these patients? How do we define those patients who should be or can be treated with monoclonal antibodies? And this is just looking at an endotyping that has been proposed based on the expression of certain cytokines in the nasal polyps. And as you see in the lower part, these are the more severe patients. They have really tremendous expression of interleukin-5, IgE, ECP. They are a type 2 immune reaction complicated by the impact of Staphylococcus locally, Staphylococcus aureus. These patients have asthma in 70% of the cases, and they always have nasal polyposis. And in that kind of patients, we have done a first study with 60 patients using a monoclonal antibody in chronic rhinosinusitis with nasal polyposis, a randomized clinical trial, which showed that by this treatment within 4 months, we can reduce the polyp score by about 2 points. So we go from 5 out of 8 to 3 out of 8, which is an enormous relief for the patient already. And you can see that reflected in the morning peak expiratory flow, which increases. And certainly, if you look at the right side, the patient's quality of life here measured as the SNOT-22, with an enormous gain for the patient. About 3/4 of her complaints are gone by this treatment within 4 months. And of course, we have to learn more, and current studies are looking at 1 year of treatment in this patient population. So we come from clinical evidence, and there has to be much more done. So we are just currently talking about 1 phase 3 clinical study that will be published probably next year. And that has to still be translated then in health economy and evidence. Does it make sense to treat these patients with such a treatment instead of doing topical steroids and repeated surgery? Now, if you ask the patients with 4 or 5 surgeries already, I guess they would say, please give me something else than another surgery, because that one also will not probably solve the problem. And finally, we have to adopt that in daily practice, but we are currently far away from that, and that we should certainly discuss who finally would or should profit from such a treatment. I think what we have to realize is that the diagnosis of nasal polyposis per se is not enough to decide who is a candidate for type 2 monoclonal antibodies, but we have to not just look at the clinical side, we also have to look into biomarkers to identify these patients, and then if they are type 2, which means they are involving eosinophils, IL-5, IL-4, IL-13, IgE, then we have to decide in these patients what we do with what of these treatments we might start, and finally, also like in asthma, how do we combine these treatments? What is first preference, second preference? So there's a long way to go, but I think it's an absolutely profitable way to go for a small group of patients with quite a severe disease. And the first steps we have to undertake to actually not wait until they had 3 surgeries done is recognize them early as nasal polyp patients, much earlier than they are recognized today, and then send to maybe centers where there can be a better care provided to these patients. Effective treatment, yes, there is surgery, but not solving all the problems, or you do a kind of surgery that is not done everywhere. So you have to look at the effective treatment for each of these patients individually, monitor the treatment effect, and monitor, of course, also the evidence, the health economic evidence and cost effectiveness of this treatment to have a patient who finally has a near to normal life with these new biologics. And I'm absolutely convinced that that will be possible in a population of patients.